Hello, and welcome to another edition of the Front Page on GNAT TV. My name is Andrew McKeever. I'm the managing editor of the Manchester Journal. It's my pleasure to be your host today, and it's also my pleasure to have with us in the studio Mr. Thomas Dee, who is the president and CEO of the Southwestern Vermont Health Care. Tom, welcome to GNAT.
Thank you, Andrew. Nice to be here.
Great to have you here. Tom has been the CEO of the Southwestern Vermont Health Care since 2009. He's overseen a very interesting period in the hospital's history, I guess it's fair to say, which has included also a new collaboration with the Dartmouth Hitchcock Medical Center over in Hanover, New Hampshire, and perhaps we'll have a chance to talk a little bit about that along with a few other things. It's certainly an interesting time, I would think, to be a hospital administrator with the arrival of the Affordable Care Act and possibility of single-payer coming into the picture. And we'll have a chance, I think, to talk a little bit about that. But first, Tom, just to get us started, can you bring us up to date on where things stand with the situation involving the hospital in North Adams that recently closed? That was kind of a sudden and unexpected development, I think, for everyone. I'm sure it's probably meant that your hospital has been receiving more patients from the Northern Berkshires area. Can you tell us a little bit about how that's going and what impact that has had on your operations?
Sure. Andrew, we were surprised, to be honest. I think we were surprised. We knew North Adams was having some financial challenges, being in bankruptcy and coming out of bankruptcy. But what surprised us was the speed at which they announced their closure. Mm-hmm. I received a call from their CEO, I think on that Tuesday of the week, and he told me they were going to close as of Friday. So we've had to gear up. Now, the majority of the business in North Adams, the migration goes to Pittsfield. Most of the physicians are on the Berkshire Medical Center staff. They all have licenses in Massachusetts. Very few have Vermont licenses. That being said, we have geared up, and we've seen an increase in business in our emergency room, primarily. We've also seen an increase in our OB business. So far, as of this week, 25 moms have signed up with our physicians to have their babies over the next 6 months or so. Mm-hmm. So we've certainly felt impact. We've seen some impact in our inpatient admissions too, and also in our physician offices. This is pretty challenging. It's a fairly large population base, and not to have a hospital down there does create some access issues. So we're trying to help out wherever we can. Right. We're trying to, work with the local employers, some of the major institutions down there to see how we can provide services, and we're here to do whatever we can do. Right.
Well, certainly an interesting situation. I'm sure that dropped out of the sky on you. And
it's not, it's certainly not common. I came out of New York market where there was a fair number of closures, but when you have an area like in the Berkshires where there's not a lot of other opportunities, it makes it very hard. And certainly, we feel for the people in North Adams, and we will do whatever we can do to help in the situation.
All right. Well, closer to home up here in the Manchester area, we have also a new development I'm sure you'd like to talk about, the expansion of the North Shire Medical, it used to be called North Shire Medical Center, now North Shire
Health
Campus.
Center, yep.
I wonder if you could tell us a little bit about what prompted that expansion and what new services are going to become available to folks up here in this end of the county.
Well, the North Shire Health Center is a very important center for us. It's a busy center. Thousands of patients go through the doors there, and it's an area that's probably the number one need is access. People need more primary care. That's just not North Shire. That's in Vermont. That's across the country. So what we're trying to do is to increase the access for patients in that area. We've renovated the top floor. We've added 5 and 6 new exam rooms, and we're adding new doctors. And when the dust settles over the next 12, 18 months, we're going to probably have up to 7 providers there. Oh, and it's pretty sizable. We're also looking to add more consultants up there who would come up here not on a regular basis, but on a periodic basis. And I think one of the keys is we're trying to come to a close on is adding telemedicine services to the North Shire campus from Dartmouth Hitchcock. Okay. So we have this Dartmouth relationship, and one of them is having access to more specialists. So the goal would be is to have a strong primary care base in the building, and then have certain specialists come to the building on an as-needed basis, and also have access to Dartmouth Hitchcock specialists out of Lebanon. And so it would be one of our first sites we do that with. We haven't, it's not up and running yet. We're working on it. We're actually working on a grant to get some funding for it. But we're pretty excited about it. I think telemedicine will be a big piece of rural health care in the future.
So that would mean someone who has an issue with health care in some way or another wouldn't then have to go physically all the way over to New Hampshire to be seen by a specialist or someone over there, but they could have their records sent by the internet, I guess, over from here to there and avoid that long trip.
And that's the intent, Andrew. You probably have to have an initial visit face-to-face, but let's use an example like rheumatology, where you have an initial visit, a consult, and then you have follow-up visits that may take place every 3 to 6 months. Oftentimes, something like rheumatology, you can do that through telemedicine. And the technology is, pretty amazing these days, and the clarity, and you can have records come electronically through an electronic medical record. So it's hopefully making it easier for the patients, not having to travel 2 hours one way for a follow visit that may only take 15 or 20 minutes. So we think it's got some real applications around here, and Dartmouth is looking for some beta sites to test this out on, and we're looking to do that.
Well, that whole Dartmouth Hitchcock connection, I know, was a very important development for you folks. I imagine that's also going to have an impact down in the Bennekin area as well. I mean, are you doing other kinds of collaborations with Dartmouth beyond the telemedicine aspect, or?
Yeah, the Dartmouth, we went through a very rigorous process a few years ago to look at potential partners that we feel are necessary in this era of health reform. And Dartmouth, for a number of reasons, their quality of care they provide, their recognition within the region, their cutting-edge technology made the most sense for us. So probably number one, we're looking for their help is to help us recruit additional physicians.
Oh, okay.
That's probably the top goal of the relationship is to work together, and through the Dartmouth name and their reputation and their networks, to be able to go out and recruit more doctors. And just in our first year together with Dartmouth, we recruited about 10 new doctors. So that's pretty exciting. And it's a challenge to recruit physicians, especially primary care. And having a relationship with an academic partner like Dartmouth is a leg up.
Yeah, because I understand that's one of the issues that's been a problem for the healthcare scene in Vermont for a while, is the difficulty of recruiting doctors to come and work here. Their salaries, their incomes don't rise to the same level as might be available to them in other states, and they're burdened with a lot of medical school debt. But this situation seems like a possible way around that.
Yeah, well, just think about it. You're a physician, you're in school, you've been in school for sometimes up to 12 years. You can come out of school, your debt can easily be $250,000. So a person coming out of their training and they're laden with a lot of debt, and open up a new business, a practice is a new business, that's daunting. So so more and more physicians are looking to work with hospitals, Southwestern and Dartmouth Hitchcock, to start their careers. And and I think that's probably the way you're going to see in Vermont. Vermont, it's a difficult place to come. The reimbursement levels are a little bit lower here than other parts of the country. You don't have a lot of support systems that many other physicians have in terms of other services in the region. So in my time here, I can probably count on one hand a number of physicians who are interested in coming here and setting up private practice. Most of them are looking for some type of employment relationship with the hospital or the health system or Dartmouth. So we think that's the wave of the future. And we also think it's going to be a wave of not just doctors coming on board, but other associate providers, nurse practitioners, physician assistants. We're not going to solve this physician shortage problem by just finding all these physicians. We're going to have to look for other type of professionals. Yeah. And that's what we're doing.
Great. Well, it must seem like a bit of a brave new world in the whole hospital scene at the moment, or at least since the passage of the Affordable Care Act in 2011, I believe. Obamacare, as some folks may prefer to call it. What has that meant for a hospital like Southwestern Vermont so far? Has that been a net benefit, or has there just been a lot of problems to work through? I mean, it's been such a controversial piece of legislation and a real change in the way the country attempts to at least pay for health care. What has that meant for you folks on the provider end? Has it been a boon or like something else?
Well, it hasn't been a boon, but it's a significant sea change that's going to take place. We're early on. Mm-hmm. Actually, Vermont, I would say, is ahead of the rest of the country on health reform. And health reform comes in, you know, some people confuse insurance reform, the health exchange, as health reform. That's just one part of it. You have the insurance exchange, which is insurance reform. You have the care delivery system reform, which hospitals are going through and other providers. Then you have financing reform. All this comes up under the title of health reform. And I guess I would say that one of the major pieces will be that the current fee-for-service system that we have all lived under for many, many years, where the more work you do, the more volume you do, you get reimbursed, is changing. Mm-hmm. We're moving towards a system of more value-based payments. It's going to be dealing with the type of care you provide and how well you provide the care to a group of population of patients is how institutions and providers will be reimbursed. So you're not going to get reimbursed just by doing more work. You're going to have to do higher value, better outcome type services. And institutions and providers such as hospitals who don't do work in a fashion that meets guidelines and meets acceptable standards of care will probably be penalized. So there's going to be more pressure on making sure that the care you provide is providing the right type of value to the patients. And that's one way of how you can control costs.
So that kind of gets to the whole issue around wellness, I guess, and trying to help people stay healthy in the first place and avoid the need to come to the hospital at all.
Ultimately, under finance reform, hospitals will not be paid on the volume side. They'll be given probably some type of lump sum amount of money, and they're going to have to care for patients with that budget of money. That's called a global budget.
Okay.
And so they'll be given a budget, and you're going to have to care for the patients and try to keep them as healthy as you can, making sure they're cared for in the right environment, not the most expensive, not the least expensive, but the right environment. You know, many patients who come to our emergency room probably don't need to be in an emergency room. They could be in some other setting like a doctor's office. And if the services are not provided in the right fashion at the right level of quality and patient satisfaction, there's potential penalties that will be impact the providers. So the model is changing. You know, it's those of us who our entire careers in the hospitals would always get very nervous when you make rounds at the hospital and you see empty beds.
Yeah.
Well, under the new world, that may not be a bad thing.
Right.
Because maybe the patients are being cared for in a different setting, which is more appropriate for their needs.
So one of the questions that I guess comes to mind around that would be, my understanding is, and you may wish to correct me, is that doctors typically felt it might have been wiser to order more tests. You know, make sure you order as many tests as you possibly can to avoid the possibility of a malpractice lawsuit later on if the patient didn't recover properly or whatever. How does that malpractice aspect play then in the scenario you're describing here? I mean, you can say we want to provide the right amount of tests without going overboard and having the patient rack up enormous costs that have to be paid by themselves or their insurance agency. But is that some way around that legal question?
Well, right now there's in the health reform legislation, there really is not tort reform legislation, so it's not a big push there. But I think what we're trying to do, and why we're working with Dartmouth Hitchcock, and why many institutions are connecting with academic medical centers, is making sure that we come together, providers sit around a table, and they look at criteria for what type of care should be provided. And you pretty much follow the guidelines that are acceptable in terms of care treatments. And what you try to do is you try to reduce variation. I mean, the more you can stick to prescribed care treatment patterns that are agreed upon, accepted, and are proven, that ends up reducing variation of care. And I think that's one way to reduce the potential of medical malpractice, is making sure that everyone's trying to follow off the same
Right.
page in terms
Okay.
of how a patient should be cared for.
Hmm.
So having an academic partner working with us who
Right.
does a lot of research is a tremendous advantage here
Yeah.
in terms of helping to educate our doctors and their physicians. And all the doctors who work for us through our Dartmouth-Hitchcock relationship now have to be certified, credentialed at Dartmouth-Hitchcock. So the bar is being raised in terms of the quality of care that we expect for all providers to have.
Hmm. That's interesting. Well, it'll be interesting to see how that plays out in the years to come. And one of the other, I guess, big issues that has been talked about a lot lately, and all of a sudden is not so far away, is the potential arrival of a single-payer plan here in Vermont. Single-payer is a bit of a misnomer. There'll be more than one payer of the government, but that's the term that seems to have come into popular use. I guess, what are your thoughts about the possible arrival of that? I mean, there are a lot of hurdles yet to be crossed. I mean, the federal government has to give the state a waiver, for one, which I guess is far from a slam dunk and a given. And there are still, I guess, a lot of unanswered questions about how much it would cost. I mean, the $2 billion figure has been thrown out there as a possible number, less the fact that people wouldn't be paying some insurance premiums. But still, there seems to be a lot of questions still floating around out there. Again, from your perspective as a hospital administrator, are you thinking if single-payer comes into being in 2017, roughly in the form it's been described as by the governor and other folks who would be eager to see that, what challenges does that pose to the hospital? Or maybe it doesn't pose challenges at all.
Well, it's change, so it's a challenge for us. I think, however this plays out, and I don't know how it's going to play out, to be honest. There's a lot, as you just mentioned, there's a lot of things that have to happen for this to take place. The Medicare waiver is not a small hurdle. But I think what it requires us to do is change the model of care and to focus on collaboration. Ultimately, if there's going to be a single-payer type system, providers have to sit down and work together to come up with the most cost-effective, highest outcome type of care for the patients. Mm-hmm. And we're focusing right now, as an example, you may have heard about what's called the Accountable Care Organization, ACO. Mm-hmm. And Vermont is now the first state in the country that has an ACO for all of its hospitals throughout the state. Every hospital in Vermont is signed up to work together and to have its physicians be involved. So we have probably 15 hospitals and close to 1,000 physicians who are now working together to come up with a potential new way of caring for patients that the providers are all working together on in terms of trying to make sure that the care is the right type of care with the right type of outcomes, and there's a high level of patient satisfaction. That's kind of a precursor towards a movement towards a single payer. It's not exactly what the Shumlin administration is talking about in terms of their model, but it's a movement away from our current fee-for-service type program. And that's what we're trying to focus on, is how can we start to change our system away from the traditional fragmented fee-for-service system to one that's much more coordinated, and it requires collaboration and trust among providers. We're not sure where it's going to go, Andrew, in terms of the single payer, but what we do know is the current system that we're working under is going to change in some format. So again, Vermont's leading the way. We'll probably be ahead of the rest of the country in terms of this, because Vermont's viewed as an incubator, a place that they can, we can experiment. So we're trying to collaborate as much as we can and look for different alternatives. The ACO, the initial ACO across the country was formed by Dartmouth-Hitchcock.
Oh, okay.
So it came out of Dartmouth. And again, another reason why we think they're a good partner is they have a lot of skill in working under these alternative payment delivery systems that invariably we know we're going to have to operate under.
Well, one other thing that Vermont has become known for better or for worse, and it's not a Vermont problem, limited to a Vermont problem, really a national problem quite clearly at this point, is the whole question around heroin addiction. The governor in the State of the State message, kind of made it clear that he felt that this was an important priority for the state to begin to really tackle and address and be forthright about. And there's been numerous articles in the national press since then that have mentioned Vermont in one way or another. So I guess I was just wondering, do you see the hospital as having a role to play in this whole situation, either by, and you may well already be doing a lot in that area, but I guess I just wondered, has there been any talk about perhaps setting up a expanded detox unit or some kind of treatment set up to help people recover or move past their addiction, or some other kind of treatment options that might be available closer to home?
Yeah, this is a this is a very challenging and growing problem, and I don't think one provider can solve it. I think there's going to have to be a partnership of providers working with the state and local government, working with the educational system, police force. We are actively involved with this. Now we're not per se a mental health provider. We don't provide. We're not licensed to do that.
Right.
But we're working very closely with United Counseling Services, UCS, which is our designated state agency for mental health, behavioral health services. We're working with a group of doctors who provide services right now, working with the local government, the police force, as I mentioned. And I believe that we will play a role in helping to come up with some type of a treatment center that can help deal with this problem. I was making rounds at our hospital a few weeks ago up in our maternity unit. And at the time we had about 8 moms and 8 babies up there. And on that given day, and this is not the norm, but on that given day, 4 of those babies were already addicted to heroin.
Wow.
When they were born. So
that's half of them.
Half of them. Now again, that's not the norm, but that's a snapshot of one particular day where it just shows that this is a growing problem, and there is a lot of innocent victims that we think it's important for our healthcare system as the largest healthcare system in Bennington County to participate. So I see us working with UCS, and I see us working possibly with the Brattleboro Retreat, maybe Rutland Hospital, of how we can come together and create some type of a treatment center. Now that won't solve the problem,
right,
but that's a piece of the puzzle towards dealing with this problem that is growing nationwide.
Right. Yeah, it's by no means limited to Vermont, as you said. And I guess one of the concerns that I've heard from a number of politicians and leaders down here is that there are really no good local treatment options. Everyone has to travel, I guess, at least up to Rutland would be the nearest, and perhaps farther than that.
So the state works under what's called a hub and spoke system. And a hub is where I think statewide there's 5 methadone treatment centers throughout the state, and that's considered the hub. And the doctor offices throughout the state are considered the spokes in the system. So our hub is up in Rutland. There's also a hub over in Brattleboro. And so what we're trying to look at to say, is the demand such that there needs to be a hub or some similar type service in the Bennington County region? And so we're working with the state, and we're working with other providers to look at that and to see, if there is a demand, where should it be? What type of services should be in this hub? And hopefully over by the end of the year, we'll have a better feeling for what needs to take place there. But I would say everyone's cooperating together. Senator Dick Sears has been a big leader of this.
Yeah.
He's been great to work with. But our other elected officials, the select board in Bennington has also been involved, and hopefully we can come up with a plan that we can all agree upon would make sense. Okay.
So one last question. We have a new federal health secretary, Health and Human Services Secretary, coming in to replace Catherine Sebelius. I guess I was just wondering, if you had gotten that job, What would be your number one priority? The number one thing you would think that that new health secretary should be tackling? Is it the overhaul of the fee-for-service model, or would it be something else?
You know, I think you raise a good point. I think that the current fee-for-service system does encourage utilization.
Mm-hmm.
And through utilization comes higher cost. So I mean, I would look towards a system that goes away from that, has some budgetary constraints, but also has incentives built into it to do the right thing.
Right.
And oftentimes, you know, we deal in the healthcare system that you have lots of penalties for doing certain things, but there's not enough incentives for doing the right thing. And I think a good example would be, you know, if you look at the state of Vermont, how the providers, and let's use the hospitals as an example, how can they work better together? How can they work, and how can we encourage providers to work together so they can collaborate and maybe share services, as an example? Sharing services hopefully can reduce expenses and also bring a higher level of expertise when you share your resources and intellectual capital together. But to do that's expensive. So if there's incentives to be able to help make those investments to do the right thing, but it's hard to get from point A to point B without some type of assistance, right. I would look to try to create systems that create those incentives. So you know, the fee-for-service system is hard to dismantle on its own, so you have to kind of create a bridge to do that. Right. And that's what I would probably look to do, is, you know, how can I encourage the healthcare system to change in a positive way? Okay. But that's a tough job. Right. I mean, that's a very, very, we all know that, you know, 17% of the gross national product is through healthcare. So to change that type of system is not an easy thing to do. Yeah,
that's a scary number when you consider the population is aging and presumably will be needing more and more healthcare than has been the case perhaps in the past.
Well, let's look at Bennington County. I mean, Bennington County, you have, you know, about, you know, 39,000 people live here, and it has one of the highest Medicare rates of the population in the country. So it's we're what's called a Medicare-dependent hospital, which means that over 65% of our patients are Medicare, very high percent. And as you have that type of population, they will consume resources. I mean, we're all getting there, and we're all going to consume the resources. So that's going to put a lot of pressure on the healthcare system and on the states and federal government in terms of the financing of that. Yeah. So we you know, so to change how you're providing care, especially for a population that's aging, is something, and then control costs at the same time. That's at times almost mission impossible, but that's what we need to do. Right. We also know it's not financially sustainable to continue at our same rate of growth. You know, I just saw a recent number that, on average, the average family spends $20,000 a year on their out-of-pocket health care costs. If that continues at the same rate, it's going to be $40,000 10 years from now. That's not sustainable. Right, right, right. Well, I guess you have your work cut out for you then, Tom. And thank you very much for joining us today. It's really a pleasure to have you in here and to talk about some of these really important issues that are going on that you're having a front row seat to deal with. Well, Andrew, it's my pleasure, and we feel very fortunate to be in this area and working, serving the population of Bennington County. All right. Well, thank you, Tom. Thank all of you for watching today. This has been the Front Page on GNAT TV. It's been my pleasure to be your host today. We'll look forward to seeing you the next time. Thanks for watching.